Here, we are preparing a live stream. Let me just share that one. Perfect. Great.
Okay.
Okay.
Are we ready, Riga? Okay, well, good morning or good afternoon or good evening, everybody. This is our next PACE session, GLOMCON PACE session, which is patient and caregiver engagement series that we do on every second Sunday of the month. Just going over some ground rules for our session. Only patients and caregivers are allowed to participate in this meeting, so it is a closed meeting. This event is not to obtain, solicit, or share medical advice, but serve only for general education purposes. This event does not and cannot relate to care provided by the kidney doctors. And for your own individual health or kidney-related questions, please speak with your doctor. So with that, I'll just do quick introductions. I am Dr. Tripti Singh. I'm one of a nephrologist at University of Wisconsin-Madison. And we've been doing these PACE sessions for last few months. With me, I have Tony, who helps me with these PACE sessions. And I'll let Tony introduce herself. And we have a guest speaker today as well. And we'll Tony, do you want to introduce?
Yes. Hi guys, I'm Tony. I'm with GlomCon PACE. Been here for about, I don't know, how long have we been doing this? Over a year, Tripti?
Yeah, close to it, getting there, right? Yeah.
It's been over a year, yeah. Also have a family member that has kidney disease, so I get this. So it's good to be here.
Thank you, Tony. And then we have a guest speaker today because we're going to talk about genetic disease, genetic kind of testing and genetics in kidney diseases. So we're very pleased to have Tessa Pitman here with us. She's a senior lab genetic counselor at Natera Genetics. She's a board-certified American Board of Genetics counseling and licensed in multiple states and offers licensure for genetic counselors herself. She received her master's degree in genetic counseling at University of Utah and has over 15 years of clinical experience. She's been at Natera for over 6 years and in her current role at Natera focuses on genetic testing for kidney disease through a broad panel approach, which I think sometimes is known as Renasight. She's a member of the Montana Association of Genetics Counselor and NSGC Renal Special Interest Group as well. She's a Montana native and enjoys travel, running, and hiking. And we are very pleased to have you, Tessa, here. Before I give it over to you, we do have a few people as well online with us who you'll see on the streaming. Rika, she's the program manager who helps us run this and put it all together. And then Nicole, who is also one of the program manager and helped us run together, and Janelle, who is kind of the research specialist and manager for GlomCon as well. With that, Tessa, I'll leave it up to you. I know our kind of format is we'll do a little bit of a PowerPoint presentation, just introducing the topic, a brief general, and then after that we do Q&A. While Tessa is giving her presentation, feel free to put your questions in the chat, and both me and Tony will look at the questions and ask the questions from Tessa on your behalf. Okay, Tessa.
Thank you so much. It's really great being here. So I'll go ahead and get started because I'm sure there's lots of questions and we want to keep this open to everybody. So I'm going to go and share my screen. So please tell me, can everybody see my screen okay? Okay, sounds great. So, as a genetic counselor, and as that was just said, I speak to providers and patients about kidney genetic testing. And so that's my primary role and what I've been doing essentially for the past 5 years through Natera. But this is more broadly just talking about genetic testing in general. And, kind of the value of that, a lot of questions come up. And so just to kind of, look at it through the lens of kidney disease. So in general, we know there is a genetic explanation probably for about 1 in 5 adults diagnosed with some form of CKD. We know in kiddos under the age of 25, 1 in 5 will have a genetic explanation potentially. And in more severe scenarios in kiddos who have end stage, potentially a genetic cause. When we look at this, I think of genetic testing largely like a puzzle piece. It's one of many pieces to the overall puzzle and explanation for maybe why kidney disease is occurring in that individual. So it's definitely a collaboration with, a clinical team, all of the doctors, all of the providers involved, and a lot of interpretation of a lot of different factors that involves that individual's particular presentation. So I think puzzle piece is always kind of the way I explain it and like to think of it, since it's not just the one deciding factor necessarily. When we do genetic testing, and if there can be an identifying underlying genetic cause, it can create, there's a lot of benefit to it when that can occur. Obviously it really kind of pinpoints maybe that underlying mechanism, which can guide treatment, research, clinical trials. Genetics is a family affair. So a big piece of what I talk to providers and patients about too is about how does this affect other family members? When you kind of find that needle in a haystack, it can be really beneficial to that conversation that people have with those family members too. The genetic testing for kidney disease is, I argue, one of the most complex. A lot of these conditions have either two different inheritance patterns, but this whole group of genes that I'm used to dealing with, and again, this can vary, but different inheritance pattern really depending on the gene or the variant identified. So depending on that is really going to determine ultimately to that risk and that conversation to family members, siblings, parents, kiddos. One question I think often comes up is the possibility of a positive result. And, there's always kind of this desire to have a number, what is the chance it's going to be positive? And this is still somewhat of a moving target. Our company has looked at just, what we've seen, and ultimately, this number can land in various ranges, but about 20% of the time across the board, depending on that indication for testing, could identify an underlying genetic root cause. So essentially get a positive genetic test result. This will vary on the reason for testing, and I often think of the high level, the level of clinical suspicion, presentation, and different factors like that, and family history. And when we think about a positive genetic test result, we oftentimes think, well, what are the most common? This is another frequent question that can come up. And again, this is in my experience, from our testing standpoint, but by and large, autosomal dominant polycystic kidney disease is probably one of the most common, but Alport syndrome is a close second. APOL1 mediated kidney disease, that's another one that's very common as well. When we look at this, though, across the board, there's, genetics conditions in general are rare, but collectively common. So while those might be the most common, we certainly can identify other genetic explanations and genes that may not have otherwise been available for genetic testing 5-10 years ago. And we also see that people in certain scenarios may have more than one genetic finding. It may explain the indication for testing, but it also may help guide risk for other things that the clinical team will help address in terms of overall risk. Another thing that may sometimes come up is sometimes that test is done, but identifies maybe not the explanation, but does just identify other risk factors. So there's a lot to discuss for a positive genetic test in general. But in general, those would be probably the most common genes that we typically see on our test. A negative result is just as powerful. We can never use a negative genetic test result to say a condition is ruled out in most cases. There's always going to be little caveats to that. But in general, a negative genetic test just says we couldn't find that needle in a haystack. Does that mean it doesn't exist? Not necessarily. So it doesn't rule something out. It is one of those things that does provide a certain level of reassurance that nothing was identified. If we could have seen it, or if a genetic test could see it, it's going to report it out. But in the absence of it, we don't want somebody to stop seeing their nephrologist. We don't want somebody to think it's not genetic. It's just something where, again, we can't quantify. We can't, find that particular explanation. And in general, in genetics, regardless if I've counseled individuals, and talked to specialists across the board in cardiology, oncology, neurology, and a negative genetic test at one point in time is helpful, but the testing is only going to improve over time. The methodology is only going to improve over time. I kind of think back when I was in grad school, the testing available, which would very much date me, but at the same time, that methodology is only going to improve. So it's always worth revisiting with your healthcare team where things are at. That is a fair question for any patient to ask about any genetic test that they've done. I'm going to touch on variants of uncertain significance. I feel like this might be a bit of a jump, but it was a question that I think we routinely get. And I think it's one of those things in genetics. I joke that we love acronyms and VUSs. We talk about it, but it's important to understand what a VUS is. So a variant of uncertain significance can pop up on any genetic test. And this is essentially a genetic change that, we can't conclusively say falls in one of two buckets. I'm very visual. I talk to patients on the phone, so I don't have the privilege of being right in front of them and drawing and scribbling in front of them and looking at their test results. So I think of three buckets. And I essentially think this is a variant that could fall in a bucket based on the level of evidence at the time that test report was sent. So it's either a variant that we have evidence to say it's harmless. Those will not get reported because it's not going to change how doctors take care of us, our kidneys. If there's enough evidence to say it's harmful, it will get reported in that category. Not every harmful change will cause problems. That comes down to that inheritance pattern again. But sometimes if we can't conclusively, confidently say one of those two buckets, it's going to fall in this middle bucket of uncertain. And uncertain essentially just means it's there, but it shouldn't change anything. Now, most of the time, these buckets of uncertain get dumped into the harmless. That's most often trending across any genetic test. That's what we're going to see: kidneys, neurology, heart, what have you. But in the event that there is any concern or questions, our job is to discuss that. So we always want to encourage questions from patients about those. Providers, this is very common, especially in kidney genetics. So I think it's important to recognize that these are not going to change how you're taken care of. They're not saying you're going to be at risk. But it's always worth exploring and making sure you understand, what they mean when you're reading this very long test result of whatever type. And then I'm just going to end with kind of what are genetic counselors versus genetic testing. Genetic counselors, that's what I am as a profession, as a healthcare provider. We work with multiple different type of healthcare providers clinically. Some work in a laboratory, talk to patients, some work in a laboratory and don't talk to patients. Our roles vary. In terms of genetic testing, you don't need to talk to a genetic counselor to do a genetic test. Just like a genetic test, you don't need to have genetic counseling after. But our role is really to help patients and providers understand the utility, answer questions so they can get good information in advance or following a test to make it meaningful for them. Oftentimes having conversations with their family members is really tricky when they're trying to understand it themselves. So we really want to help facilitate those conversations as well and be a resource. So in general, they don't equate, but our goal is to make sure that it is as meaningful as possible and address those questions and help your healthcare team as well. So I'll end with that. Hopefully that didn't take up too much time. I want to make sure there's plenty of time for questions.
This was perfect, Tessa. I think this was awesome. I think it just helps in getting a little bit of a background as to people to know. So how we'll do this now is just me and Tony will kind of ask some questions, and people can put in more questions in the chat, and we'll kind of go from there. I guess you did talk about my first question. You did talk about that a little bit in your presentation, but I guess reiterating the same thing, what would be the most common genetic, like kidney diseases, when a genetic testing would be recommended or done, or when I would say somebody gets told that you have kidney disease and should they get a genetic testing, a little bit as to on that. Yeah.
For me, yeah.
Yes.
I would say, and again, I have the perspective through our particular genetic test, and there's hundreds of genetic labs and hundreds of different types of genetic testing. So it is going to vary. So speaking from my experience, we have a panel. So it across the board is going to be looking at a variety of different types of genetic conditions related to a variety of kidney diseases. So stones or structural abnormalities, cysts, glomerular, kind of you name it. So it kind of just runs the whole spectrum. Some genetic tests are focused just on cysts. Some are just focused on, glomerular or stones. So it just kind of depends on what test is ordered, and there are a lot of options out there.
Yeah, no, that's a good point to kind of reiterate that there are different types of testing and there are different types of diseases, kidney diseases too, and there are different tests for each disease, which I
Yeah.
guess goes into my next question. And sometimes it's hard to know, are there different types of testing that could be done? I know there's so many different genetic tests, and usually it would be the doctor and the doctor's team who decides where to send it. But if I'm a patient and if I am, are there different ways that a genetic types of testing that can be done, right? That's kind of how I would say, would you, yeah. Or they're all the same. And finally, like it's like getting the creatinine, right? Like I check a creatinine, it doesn't matter which lab it goes to because it's kind of standardized across, but is it same for the genetic testing too, would you say?
So, yeah, that's a great question. I think, in genetics, we aim for consistency. And so the methodology, when one lab uses one methodology, and the other lab uses the same, the outcomes should essentially be the same in identifying a mistake, if you will, a variant, a change, which we're chock full of. We're all alike that way. But, what can kind of be a little, can vary by a laboratory is, again, what bucket is that put into? And that's going to depend. While we all use the same framework, we all rely on our American College of Medical Genetics to provide that framework of which bucket. Each lab has a little different information. So I like to think of it, for example, if you ordered the test for your patient and they had a family history, say you found a VUS, say they had 3 other family members tested and all tested through one laboratory, that laboratory now has information about, wow, this VUS actually kind of tracks with the disease in this family. That's information, that's evidence, where another laboratory may not have that. And I would say, well, from a genetic standpoint, we try to be as, again, inclusive and communicative about findings. It's just it's always going to be challenging. So one lab, again, might have more information than another lab. So that can kind of make it a little different on the resulting end. But in terms of types of genetic testing, yeah, there are a lot of different types depending on the scenario. If you have a positive result in one family member and you want to test, are my other family members at risk? You might just want to look at that one gene, that one change to say yes or no, versus looking at a whole panel of those genes. And then again, like I had mentioned, more targeted on a specific thing. So it just kind of varies. And in some cases where there's high level of clinical suspicion, it is truly, a clinical diagnosis that has very specific clinical features and you have a negative genetic test, there is more comprehensive testing out there. And I kind of think of it as if you have a high level of clinical suspicion and a condition that has a very strong clinical criteria for diagnosis, you might want to take a step up to look at the next tier of testing potentially. So.
Perfect. Thank you. So how I understand is it's like there's some known mutations that we know and we can target for them. So let's say if you have cystic kidney disease or polycystic, you can specifically look for them. Or you can kind of look and find because there's some new mutations that could be there and we don't even know if they can cause the disease, and you can look for them. And then it's kind of working with the geneticist, a counselor, and your kidney doctor together to kind of see that maybe you're the first person that we know of has this mutation that can cause this disease. Does that kind of makes a little bit more clear. Yeah.
That's kind of why it's nice to cast a
Yeah.
broader net. So I like to think of a gene like an instruction book. So at first glance, we might look at that instruction book cover to cover, page by page.
Mm-hmm.
And so we're looking at all of those for typos or mistakes, which again, we all have, but not all are harmful. Where the next family member, if there's a mistake identified or a variant, the next family member, we might just look at that page and that particular mistake. So it can kind of get tiered that way. Whereas if we don't find an explanation on that first test, you might start looking at more instruction books page by page. Does that?
Yeah, I think that's a very good analogy. I like that. That makes it very clear for me to understand as well.
I have to visualize a lot of
Yeah.
things because that's how I operate. So I'm glad that helps.
Perfect. And then just kind of feeding on to different labs. We do have a lot of these commercial where you can check this ancestry. And can they report kidney disease? Like you're at risk of kidney disease, can they report that? And is it valid enough from them if you get it, or what to do if that happens? Or if I have kidney disease, can I do it with them rather than doing it from the kidney doctor?
Yeah. So I have reservations about direct to consumer. Have I done direct to consumer? My 90-year-old grandmother? Yes. I think they're fascinating and they're amazing. And there's really, really interesting information there. But from a diagnostic standpoint, do we want somebody to take that information to say, I have this? No. There's limitations in the interpretation. There's limitations in the methodology that I find that are not always so clear. So it's really important if you've had that test to bring it to your doctor or ask those questions to your healthcare team. Ask questions. It's a fascinating thing that we can do genetic testing on so many levels, but it's not considered diagnostic. And so, because we want to really reserve that for information that is validated. And so that would be it. And kind of what it's looking at. So like I said, as a laboratory, we're looking through each page cover to cover, essentially. Sometimes with those types of tests, we don't know necessarily if they're looking at just 2 pages and saying it's negative, or looking at all the pages and calling something like a VUS diagnostic. So, those are some of those nuances. So always encourage individuals to talk to their healthcare team if they have one of those.
Perfect. I love this book analogy. It kind of makes it so clear, which is awesome. Tony, do you want to go ahead and ask, and we'll do a little bit more specific questions, and then we can come back to some of the other ones too. I think you're muted, Tony. Technology.
There we go.
Perfect. Yeah.
Okay. So there were some questions that came through Facebook. And some of these are actually regarding FSGS.
Mhm.
So one of the question was, what is the standard protocol if FSGS is found to be genetic? So I don't know if Tripti wanted to weigh in on that, or
Yeah, so I would say usually when I see a patient with FSGS, we don't tend to start with genetic testing. Again, I think one of the I'll take the cues from the slides that Tessa presented. It's not one of the diseases which is where we know a lot of mutations that can cause FSGS. And so our guidelines also recommend to treat FSGS, and if somebody is not responding to the first line treatment, which is prednisone, that's when we call them either steroid resistant or steroid dependent, and they need a second line therapy. That's when it is recommended to consider genetic testing at that point of time, because that suggests that there might be there's a higher chance of finding that needle in the haystack. And so usually we as nephrologists send the genetics testing at that time. Again, how it changes the management is very different, and it depends on what the mutation is. It depends on how the person is clinical presentation is. And I know we can talk about that, because you could have the same mutation, but it could present as a very different disease in one person compared to another person in a different family, or even in the same family. And so same mutation does not exactly present the same way, and clinically, it in some diseases, yes, it does, but in certain diseases where it's not a specific mutation, it does not. And which is what we see in FSGS, that I could have the mutation and I might be on dialysis by age 20, but there might be somebody else with the same mutation and they have not that severe CKD, meaning they might have FSGS, but they might respond. So it's just how the genetic mutation presents its phenotype is what we call in medicine, or clinically, it's very different in different people.
Mhm.
So I think it's also, that's where that kind of talking with your kidney doctor as well as the geneticist, and I think together co-management is what is really important with these diseases as well.
Okay, so which goes to the second question. How does the genetic FSGS impact transplant as far as reoccurrence?
Yeah, that's a very good question. So usually genetic diseases, if you do find a genetic mutation, it should not recur in the transplant. And that's one of the important causes that we do genetic mutate testing before transplant, is that it should not recur, because that new kidney that you get should not have the same mutation. Again, it depends on what's causing that FSGS, because there are some mutations which could have their clinical significance within the kidney cells, right? So you're not making that protein which is in the kidney cells that's kind of damaging those cells in the kidney, and you get FSGS. There are some mutations which are not in the kidney cells, but they are in other cells in your body, and they are making something, let's say a soluble factor or something in your blood, and that's causing damage to the kidney. So it totally depends on what the mutation is and where the mutation is. Most of the FSGS that we see have mutations within the kidney cells, majority of them, not all of them though. So majority of the FSGS, if you find a mutation, would recur much less compared to if you don't find a mutation at least. And that we can figure out and tell you before if we find a mutation, because we know where the mutation is. And what is the effect of that mutation in the kidney as well. And so it will be your kidney doctor, your team will be able to tell you if this is one of those recur or not. The other thing which is really important for transplant would be if you have living donors, and if you really have to figure out who can donate the kidney if you have a living donor in the family, and if they would be safe. Like I just said, the same in the family, two people can have the same mutation, but they can present very differently. And that's what we call as epigenetics, or their different names. And Tessa might know the names better, but they might present. So let's say if I have the same mutation and my brother has the same mutation, but he had kidney failure and I didn't, and I would want to donate, but if he has a known mutation, it's really important for me to be tested before to make sure I don't have the mutation, because so far I don't have kidney disease, but I could be at risk of having it later. And that kidney that I give him will also have the same mutation. So it's not good for him or for me, with both having that kidney with the mutation, if that makes sense. Because it's really hard. I've talked to families where they really want to donate and they still wanted to donate when they have the mutation, because they're like, my kidney is working fine and maybe I'll never have it. And yes, maybe you won't have the disease ever, but maybe if I give that kidney with the mutation, there's something in that person that's causing them to have the disease with the same mutation. And so maybe that kidney that you give your loved one will have the same disease or FSGS in the other person.
Right,
It's
right.
getting very confusing, but
Yeah,
hopefully this helps.
which
I-
goes to the next
yeah.
question is kind of like what you were saying. At what point should the other family members be tested if genetic FSGS is found in a patient?
Yeah. Tessa, do you want to take that, or for any genetic disease, like if not just for FSGS, if a mutation, if
Mhm.
I get like, oh, you have a disease, be it FSGS, be it polycystic kidney disease, be it cystic kidney disease, or whatever be it, or Alport's, does it mean that I kind of call all my relatives, my brothers, my sisters, my cousins, everybody, my parents, and ask them to get tested? Like, what do we do? Yeah.
Exactly. Yeah, that's a great question. Again, genetics is a family affair, and we know families are complicated. So in genetics, we always want to encourage sharing this information, however that is. When you have, the transplant's a great example. There's a lot of there's a lot of genetic conditions that we refer to it called penetrance. So penetrance, and again, another analogy, visual aid, I think of it like a dimmer switch. So if you have the mutation or have the variant, some people in the family can have the same variant. So think like you're turning the light switch on, you test positive, you all have the same variant. Some variants like PKD, those are highly penetrant. The light switch is on, the dimmer switch is going to be full on bright. Those lights are on bright, you're going to develop cysts. That's the general rule of thumb with PKD1 especially. Now, there's going to be lower penetrant genes. So that's going to make that family history look a little, everybody's negative. Nobody else has kidney disease. So the light switch is on, but the dimmer switch is off. So it looks like the lights are off. They don't have manifestations. Maybe they go in, maybe they've had a few, urinalysis that show some intermittent proteinuria or some other things, but overall, their kidneys are fine. It's never been a concern. So that penetrance, that dimmer switch, is what makes it kind of tricky. So when I talk to families about genetic testing, when it's a highly penetrant condition, it's kind of like this, if you have a negative family history, we're going to think different things. Maybe it's spontaneous in you, etc. When you don't have when you have a negative family history and it's a lower penetrant gene, the genetic test is probably the most reliable way to say who's at risk or not. Because you can have no manifestations and still have the variant, and so therefore maybe be at risk post-transplant. Again, donating, or you putting that individual, that relative at risk. So there's just things to consider there. The other thing is kids. We always get asked about, well, do I test my kids? And so, this is in genetics. Again, there's never a right answer, especially when you're talking to a concerned parent, but we just want there to be as much information, good information, so you can make good decisions and ask great questions with your nephrology team. So in general, testing a kiddo for a adult onset disease in genetics, we kind of were like, why not wait till they're 18 and they can make that decision on their own? It's not going to change how they're managed. If that kiddo already has existing kidney problems, it's a different conversation because there's something already going on. Could this be a contributing factor, if not something more? So again, it's kind of a conversation to have, with multiple people. For those low penetrant genes, I think across the board, if it's not going to change management, have those conversations in advance. It's okay to take your time. You don't need to test everybody immediately because you have to know, because it may not change anything. Whereas if it is something that's going to be directly, affect management, it's okay to maybe accelerate those conversations and consider testing sooner than later. But it's lots of questions. Always encourage people to reach out. I think one thing we think about with testing minors or asymptomatic family members for a known variant in the family is just, there are risks. We have great legislation for health insurance, so there's no discrimination. You can secure a health insurance policy regardless if you're at risk through a genetic variant, but there's loopholes to that. And there, one thing that escapes that is life insurance. And it's really, in my experience in pediatrics, talking to parents about securing a life insurance policy on their kiddo prior to genetic tests, that's a complicated conversation. And life insurance isn't something that everybody has on their radar. Whether or not somebody, whatever value they place on that, just for parents to be aware that is, could factor in at some point in time. So again, good to have good conversation about the risks, benefits, and limitations of testing somebody who's a minor and an asymptomatic minor at that. Does that kind of get on a little bit on that?
Yeah, I think that's really helpful. Also, I guess on the same question, if I can ask a question as to who tells, if I get it, who tells me what the penetrance would be? Who tells me, oh, I should go and ask my other, who's it, so people know. Yeah.
Yeah. Oh, you mean so who
what I know there's some low penetrance and some high penetrance, and how as a person, if I have kidney disease, how do I know that this is a low penetrance disease and it's okay if my family members don't have the disease, it's okay not to be tested, but some of them, like polycystic kidney disease, is high penetrance, and this maybe they need to go to a doctor and mention it to their primary care doctor, and I should tell my siblings about this, right?
Yeah, I kind of think of it like if you remove the genetic test entirely, what would you say to your family? Positive, negative, whatever. Like, just let's move that puzzle piece to the side. You
Got
still
it.
want to share, that family history is so important. I oftentimes joke with patients I talk to that I rarely ask my dad if he has any concerns with his kidneys. I see him multiple times a year and talk to him. It never comes up, and it's what I do. So these are not common conversations to have. So regardless of genetic testing, just being, exploring that periodically. I think CDC came out with a questionnaire for families to use around Thanksgiving to
Oh,
talk
really?
about health history. I don't know if it's still there, but I would say that it is something that it's that idea that that family history is going to be the most important thing to share, because then that's going to prompt other family members to have a conversation to say, hey, my sister is seeing a nephrologist. They don't know what's going on with their kidneys, but the kidney function isn't quite where they want it to be. Or, my brother has a specific kidney problem. It's this, they don't know what caused it. It just prompts that conversation with their primary and potential referral to kind of keep an eye on things, a little closer than they otherwise would in the absence of a positive family history. Does that make sense?
Yeah, definitely. That was super helpful. Yeah.
So, okay, so I do have another question real quick. And this is kind of common because let's just say somebody had tested negative like maybe 15 years ago on genetic testing, right? And since it's constantly evolving, right? So is it worth doing a repeat test down the road later? Even if it came back negative, nothing was found, like let's just say 10, 15 years ago.
Mhm. Yeah, I think across the board, revisiting genetic testing over time is really important. The methodology has gotten so much better.
Mhm.
I think we used to just, some genetic conditions. We just looked at certain pages in that book, and that's all we did before we had methodology that allowed us to look at the entire book. And when I say the entire book now, I even mean there's pages in those books that we still can't see. So over time, there's going to be, we're going to have the ability to look at more pages and see more things on each page as well. Sometimes there's pages missing, 10 years ago, were we able to see that? No. Historically, we could see if a book was missing. We could see maybe if a couple of books were missing. So things are always improving. I would say in kidney genetics, I think of it on a timeline, kind of like compared to cancer genetics. Cancer genetics has 30 plus years of genetic testing. They know a lot. They've seen a lot of things. The testing has evolved a lot. Even to a woman who say has had breast cancer 10 years ago, we would still want them to revisit genetic testing because we are identifying, there's better methodology, or potentially there's different mechanisms in the genes tested, or there's additional genes that have been introduced to potentially cause certain types of health problems. So kidney genetics, we know a lot. We're going to know a lot more over the years, though. So absolutely worth revisiting. I think there's the retest and there's also kind of the reanalysis, are two different things. A retest is in a couple of years, maybe do need a new sample, new order, submit a whole new test to whatever laboratory you're looking at. If you've had a test and it's been about a year and you had some of those VUSs, maybe one was kind of suspicious because of what you have. And then, that variant maybe wasn't very strong, didn't have a lot of evidence, but the gene is associated with what you clinically have.
Mhm.
Revisit. That's not a retest. That's have you talk to your provider and say, hey, has anything changed with that VUS? Do we know anything more? Your provider can call that laboratory. We take those calls all the time and we welcome those. Patients that I've spoken with, I always kind of probably too often give out my email and have them just like ask me, and then I'm happy to follow up with your provider, just so people can stay, engaged. Again, it's a collaboration with patients as well. So that reanalysis is just essentially starts with a question and some curiosity.
That's great. Thank you so much for that information. Yeah.
I guess
Ah,
oh,
go ahead.
Tony, do you wanna? Go
Nope.
ahead. I know
Go
we have
ahead.
so many questions for Tessa here. It's one of those topics which is like new and upcoming in kidney diseases, like you said, and it's been cancer for a while. I guess one of the things is um so let's say I have some kidney disease that's known to cause with a genetic mutation. Can I know what the likelihood of would be if I'm doing family planning, and how do I get to know that, and how do I plan kind of for that?
Absolutely. So you're saying if you have a kidney disease and you have a genetic test, this is probably why. Fair.
Yes.
That would.
Mm-hmm. Yes.
Yeah. So I mean, that's something that's a whole other conversation, and it's a big
Mhm.
conversation. And again, it kind of aligns with that idea of, testing an asymptomatic family member or minor. Lots of information to get in advance. So we really encourage meeting with oftentimes like a maternal fetal medicine doctor in the context of a young person looking to start a family or looking at those risks. So that again, MFM is somebody you can work with the OBGYN to, really focus on mom and baby to make sure they stay happy and healthy and, address anything if something comes up and really discuss those risks in advance and other risk factors. MFMs follow, women who have diabetes and high blood pressure with no known genetic explanation. So they're going to follow you based on that, any of those risk factors. Oftentimes there's a genetic counselor that works with an MFM in a prenatal setting as well, and they may discuss potential genetic testing that's available either before a pregnancy. There is some pre-implantation genetic testing can sometimes be used for people who have a known genetic risk factor. That, depending on that could be up to a 50% risk or 25% risk, depending if it's recessive and both partners are carriers for that condition. So they can address that, talk about what that looks like from a pre-pregnancy standpoint. There's testing during the pregnancy and there's testing after the pregnancy. I like to think the testing, regardless of when it occurs, you just want to make sure you have the right doctors in the room, So you want to make sure that you kind of enlist all of the right people in advance, but it definitely gives you kind of an idea for a planning purpose. And we really encourage probably having conversations in advance.
Perfect. I think this was awesome because I think sometimes people just don't know about maternal fetal medicine. That's whom you want to reach out to, and they have a genetic counselor, and they can help you walk through even before, during, or after the family planning or pregnancy kind of thing.
Absolutely. Yep.
Yeah. Tony, I guess, do you want to ask the question? I know there was a question.
That came through the type
Yeah.
form. Okay, so I guess it came through as an honest question. I'm just going to go ahead and read it and
Yeah,
then.
which
Oh,
is
yeah.
fine.
Okay.
Yep.
Our son was diagnosed with nephrotic syndrome 6 years ago at the age of 6. He has not had a biopsy or genetic testing, as we were advised that neither could change his course of medical treatment since he responds to steroids and rituximab to keep him in remission. I'm hearing about more and more genetic testing was advised by another nephrologist to consider it. We were wondering why and how genetic testing could be helpful for our son in this disease.
So I'll maybe take some part of it and I'll see if Tessa has
Hmm.
more to add to this. But I would say, so I'm not a pediatric nephrologist, so I'm not so up to date on pediatrics as I'm an adult nephrologist. I take care of patients above age 18, but I work closely with pediatric nephrologists as well. Usually, like I said, their guidelines are very similar to what adults are. We usually don't consider a biopsy or genetic testing in peds or kids a little bit earlier. So that's like what we do for patients, young patients, that we won't do a biopsy or if they have nephrotic syndrome or do a genetic testing. But the guidelines say that if you are requiring a second agent beyond the prednisone, that you're not responding to the prednisone or are resistant to the prednisone, then consider kidney biopsy. And then usually I tell my patients when I talk to them about genetic testing, it helps both you and me kind of plan for future as to what is, if we find a mutation, what is expected. Like we know some genetic test mutations that would lead to one disease. usually how it presents in people who have this mutation. So you kind of a little bit know about what to expect in future, because these are diseases we can never cure. We can treat them, but not cure. So there's a lot of uncertainty that is there. And sometimes knowing that extra piece helps you plan for it that way. The other thing it also helps is again, when going forward about planning for transplant, and that would be. So I think it's really hard for us to kind of, it would be a conversation that you would have with your kidney doctor. It might be worthwhile to discuss with the geneticist or a genetic counselor if it would be helpful or not. And then I think genetic testing in a minor is always something which Tessa, I think, went on a little bit, has its own kind of things to consider about if you would want to do it or not as well. But that's kind of the guidelines that we have in considering genetic testing in FSGS, is what I would say. Tessa, do you have anything more to add, would you?
Yeah, I would just say in general, this is a really common thing that comes up I think parents are really motivated to like, you are looking at all the information possible and you're your child's advocate. So these are great questions to ask. When I see a question like this and your kiddo is 6 years ago, was genetic testing for kidney disease as readily available or accessible? Was it cost prohibitive? Was it something that was in the guidelines? It really was not. So it may not have been something that just was part of that toolkit at the time, that now it has a little different, it is a little bit more accessible. It is a little bit more, something that I think is being considered. So some of it is just that revisiting and making sure. I always encourage patients and parents, like, tell your healthcare team that your interest or your concern, or just maybe you want to talk to a genetics professional, clinically. You are always welcome to get that information. And I don't know, no one is necessarily stopping you from getting that, but we have a lot more information now than we did 6 years ago, even. And talking with a genetic counselor, kind of back to that, or genetics doesn't equate genetic testing should be done, but at least it gives you another layer of information about what to consider in, moving in that direction or not, because we know that sometimes we can be tested and it can be negative. Would it change anything? No, but at least in that way too, also when, again, another visual aid, I think of a Google map from point A to point B, there's no extra stops, you're going in the right direction. The genetic test just ensures if it's negative, you're not adding any additional stops to that trajectory in general. So I encourage parents always to ask, though. It's a valid question. And over time, it's going to become even, it's just really encourage parents to ask those questions.
Yeah, I would say talk to a genetics counselor. I do think it really helps before you think about getting a genetic test, because understanding both the sides of it, like why to get it and what it adds, and then making a more a decision about getting it tested or not, probably. Yeah.
So, I mean, which raises another question is, some people would want to get a genetic testing done, but they don't get the referral because um, they're responding. Now, is it something that they need a referral to get one done from their nephrologist to get a genetic testing done, or am I making any sense?
No, you are, Tony. I do think you need a referral for any of these genetic testing. I do think they
Okay.
need a little bit of that interpretation, because you wouldn't, like, I think it's really hard to know what to do with these. I know we kind of talked about there are some genetic tests that you can do commercially,
Okay.
and which are focused more on ancestry, but they can find some of the other mutations that might be, and they've now started reporting some of them, that this is higher risk of this disease, this is higher risk of this disease or cancer or something. But I think when we are talking about for specific kidney disease, that because it's not always, and I would say the penetrance would be the best example, but it's not always having the mutation leads to a disease, and how to interpret it and which mutation to test for also is very different, because every disease has different genes that could be affecting it. So I think it is still complex enough and nuanced enough that I am still learning, and it's evolving field, and I don't know so well either. So I do think it would be really hard for somebody to do that. Saying that, if you have discussed it with your kidney doctor and if they are not interested in ordering a genetic test, there's nothing against getting a second opinion and talking to another nephrologist. Nobody's stopping you. I think you're your best advocate. I always tell my patients, get a second opinion sometimes. I have nothing, I don't feel anything bad in if somebody goes for a second opinion. If I miss something, I would rather have it known to take appropriate care of my patient. And if your kidney doctor feels bad about you getting second opinion, then maybe that's not the right fit. And you should advocate for who's the best for you, and that's what you should. But if you feel like it's something that bring up with your doctor, have that conversation, listen to them, what they say, if it is appropriate or not. And if you're not matching, then you can always talk to another doctor, I would say.
Right, right. So have you come across some patients or a situation to where when they run it through the insurance and the insurance says, well, it's not medically necessary?
Yes, a lot of times. So I know Tessa was mentioning it, and it was such an ordeal. I would say 10 years ago, it was a huge ordeal to get a genetic testing. It would take, I don't know how long for us to get the prior auth. There are only very few labs who were doing it. Maybe it's a research lab. I've sent my patient sample to research lab, and it's just for FSGS, like in Boston, this children's hospital lab does it. And so it was a whole ordeal to get it done. I do think it's so much easier now to get it done. It is also much cheaper to get it done if your insurance does not cover it either, to be honest.
Oh, okay.
But most of the insurance do cover it now. I haven't had so many issues with the insurance not covering it as much. So it is a lot easier and cheaper. And because it's cheaper, I think insurances are covering it too, to be honest. And I do think, and that's why I think a lot of kidney doctors are also getting more up to date on more figuring out where to do it as well. They're different. I have a genetic counselor in my clinic who helps kind of get the prior auth and figuring out with the insurance piece of it. So I don't have to do it myself or my nursing staff, which makes it a lot easier.
Right.
But there are a lot of different labs who do it. Some do it where they do the whole panel. So you can't do, like, let's say if you have FSGS, they can't do just for FSGS. They'll do for the whole, all like these 300 or 400 genes. There are some, and there's some advantages and disadvantages of that. And there are some labs, and these are all commercial labs that I'm talking about, not the like Ancestry and me, not those labs, but like medical commercial labs where you can send and you can do, like, let's say just for FSGS. My patient has polycystic kidney disease, and they are just going to look for polycystic kidney disease. And they have some disadvantages because, let's say, if you're the first person they only look for certain genes and certain mutations, and they also look for those uncertain VUS, which are those where we don't know if they might be causing, but they still have a restricted panel. So there's some advantages and disadvantages of everything. And that's what I think it's really important to have that conversation with your kidney doctor and the genetics counselor. And I work with my genetics counselor as to, well, I really think this person has something which is maybe genetics because they have a family history or something. And then if I don't find anything, I will repeat that person's test in a year or 2 years again, just because I do think it really helps that we didn't have that knowledge before and now we might. Or for that person, I might send it to, if I didn't find anything, where they do the whole panel, like the whole kind of panel, because maybe I find something which wasn't tested by this lab, but by other. And it's really hard to know which lab does what testing, and a lot of them tell it, but it's really hard for a kidney doctor to keep a track of everything which lab does. And that's why having a genetic counselor and talking to the genetic counselor is really helpful. I know it was a long answer, but hopefully.
Mhm.
That kind of helps.
Thank you.
That's so many good points. I just to add on to that, yeah, there's a lot of fine print on a genetic test result. So we are always happy to help facilitate understanding what that means and doesn't mean. I think that is just a tricky part of genetic testing. And we know, you know, your healthcare team is incredibly busy and they are juggling a lot of things that are very important. So as a genetics professional, we want to make sure we can provide as much clarity about what a test is, isn't, and what it can and cannot do. And on the interpretive side, you know, what does this mean and not mean, and some, you know, kind of suggestions about next steps if needed. But in general, like when I think about a commercial lab, they generally need to always be ordered by a healthcare provider. So a patient can't just like have it ordered or just get it done. But that's really important because that clinical history that your healthcare team has optimizes interpretation of results. And that is ultimately what we want to make sure we always do the best, because that's going to guide treatment management. It's going to, those next steps, how to talk to family members. So it is certainly a very collaborative thing. Never want it to be a barrier. You know, for my particular group, that's all we do is kidney genetics and talk to patients and providers. And so we talk to people in advance too. So if they have questions about anything, they can ask us and then they can go back to their doctor. And again, you know, just to find somebody that advocates for you is, and getting good information is what we want to make sure you get.
Perfect. I know we are at time at 12:30 here, but it was such a pleasure to have you, Tessa. I learned a lot. I'm sure people and Tony learned a lot as well, both of us, as well as the people who are listening. So thank you again so much for your time on a Sunday, and in kind of teaching us and our kind of listeners here as well.
Thanks so much. It was great being here. Anytime I can be a resource, you're a great group. Thanks for all you do.
Perfect.
Thank
Thank
you.
you, everybody.